our governing body. It's a relatively short meeting today, I hope, because we do have to keep on time because we have some presentations being done for us for some people who have got a very tight time slot, and they're going to be done in the part 2 sort of development session part of what we're doing. So just in terms of apologies that I've got at the moment going through the agenda, I've got Peter Scott from NCIC, Gareth Coakley, member of the governing body, Denise Leslie and Julie Clayton. And I think obviously we could put Deb Lee down. Oh, Deb, you're here. Sorry, I've just seen you.
Apologies for being it.
Okay. Just in terms before we act. Sorry, Peter, you got your hand up. I do apologise. Go on.
Just say Louise Mason Lodge should be joining us, and
Okay.
Louise has been doing some interviewing this morning for working with Cumbria County Council, so she should be joining us shortly.
All right, and I think Helen Horton as well. I don't see Helen unless anyone. So, apologies from Helen as well. You've got your hand up there, Mandy. Is that to tell us that to tell us Helen? Right. Okay. Thank you. I think we've covered everybody there, Brenda, in terms of the apologies and our normal membership. But just before we started, though, I just wanted to say a few words in relation to Helen Horn, who some people will know very well in relation to the work that she's done publicly, both as a councillor and both as was the Health Watch chair before she stepped down a few weeks ago. But sadly, I think as most people know, that Helen died. It's actually a funeral today. I've sent apologies to her 2 sons to say that we couldn't make it, or I couldn't make it to attend the funeral. But I just, as a sort of mark of recognition, specifically as it's our public meeting, but for Helen, I just wanted a few moments of reflection, not a minute's silence, but just a few moments of reflection, just to thank her for the work that she's done for this community, but also she was a member of our primary care committee as well, and she did a very good job there. Just basically supporting people who are vulnerable and patients and the public, and making sure that that voice was heard. So just a few moments and then we'll start the meeting properly, please. Okay, thanks everybody. So just in terms of the next item on the agenda, declarations of interest, I don't think there are any specifically other than the ones we have noted down. Is there anything that anybody wants to say in particular? Nope. Okay. Next thing, just in terms of the minutes of the governing body, which was the 20th of May, and thank you, John, for sharing that in my absence, appreciated. Is there anything in terms of accuracy that we want to do? So I'll just go page by page. Page 1, page 2, page 3, page 4, page 5, page 6, page 7, and page 8. Okay, happy with that. We'll accept those as a true record of the meeting then. There were no specific actions or action logs dropping out of that, but is there anything that's not on the agenda today in terms of a matter arising from those notes that anybody wants to raise at the moment before we move on? Okay, that's fine. What I was going to do, I did, for those that joined the meeting sort of around about 1 o'clock, I did say I'd get Suzanne on first because she's got to leave at 1:30. So rather than going straight into the COVID update, I was going to propose, or I was going to ask for Suzanne to do item 9, which is the CLIC report. So I'm going to hand over to yourself on that item, please, Suzanne.
Thank you, John. So this is the 7th CLIC annual report, and it's my first one that I've coordinated. It's in draft form so that we can take comments from the governing body or improvements or amendments. So I'll just briefly talk about the headlines and the papers there to read, but it was a strange report to write because it was a bit of a strange year this year. So for much of the year, there was myself and the admin team because we'd had a number of retirements, and then the colleagues that were working in a pooled way with CLIC from NCIC returned to NCIC. And then we had COVID, so a lot of the programs we were delivering were suspended so that it would free up capacity for frontline staff to be redirected to the supporting the pandemic. So I'm hoping that the report, it's written in a slightly different way to normal, but I'm hoping it reflects the achievement done this year, and also I've highlighted some of the challenges and issues as well. So just in terms of the achievements, so some of the achievements this year from the CLIC team was that we supported frontline recovery services. So a lot of the staff were redeployed into NCIC, and they actually had a hands-on role in supporting the redeployment hub, coordinating volunteers across North Cumbria with colleagues from different sectors, and also helping to distribute donations. So they had a very active role. It was quite a positive experience. I think I did a 6-month update that reflected, actually it gave them opportunity to use their skills and the learning that they got through CLIC in a very practical, hands-on way. So throughout the pandemic, we did maintain some essential training. So that training that supported staff wellbeing, so we kept wellbeing and resilience programs going, but also we provided support for leaders through COVID times by maintaining the coaching hub and some essential development for leaders. Those programs that we did deliver, we adapted to virtual formats. So we rewrote the way they were presented so we could deliver online, and that's been relatively successful. I think it's helped to increase access to, by doing that, though not all of the programs actually suit themselves to delivering online, particularly when people are joining in an open forum and you're trying to create sort of psychological safety so people can open up and share stories. We can't always do that in a very virtual way. So we took the time where we weren't delivering to actually refocus how we were going to approach CLIC this year. So we met with our partner organisation representatives, and we looked at how we could add value to what development was happening into organisations' own development plans, and look how we could deliver the needs of the health and care strategy. So we came up with a refresh programme, and this year we're going to be focusing on doing more learning and sharing of innovation, working together and co-production, looking more closely at personalised care and prevention. Again, continuous improvement and reducing waste and increasing productivity has been one of our core themes. We will maintain that. Supporting compassionate leadership and cultural behaviours, as well as maintaining coaching, wellbeing and resilience. But apart from delivering training programs, because we know only 10% of learning really occurs in the classroom, we're going to be using much more of the CLIC website as an online platform for learning and sharing, and we're also going to be creating some active networks to connect people across the system. We've been successful in recruiting to a couple of our vacancies, so we should have a fully established team by the end of August, which is really positive. Whilst we've not been as active this year, and you will see that reflected in the data section, we have been able to maintain the quality of learning. So we've got 99% of attendees recommending the programmes to college, which I think is really positive for us. And we've also taken quite a lead role in sharing learning from COVID. So we did some work on behalf of the system executives to take the themes from across each of the organisations, and also did a paper on how you make change stick. And we've picked that up and developed a learning campaign, which we're running through CLIC. So we've shared stories of how we're embedding learning from each of the partner organisations. We've set up a lunch and learn across the sector, and that's been really quite positively well received. So in terms of the issues we faced, I probably touched on the main ones, which are the capacity of the team's been significantly affected this year, and also because we've had to pause because of the pandemic. But we're back on track. I think it's fair to say, with the new recruitment, a new approach, we've got the programmes up and running. I would say we're walking rather than running at the moment in terms of how we're functioning, but we are definitely getting there. And I think by the autumn, we should be back to full steam ahead. In terms of risks, we've got a really clear purpose for Click and a real approach on how we go on, but it's really relies on gathering intelligence for organisations to know where we need to target our need. And so it really does depend on collaborative working, and the capacity of people to do that at the moment is really stretched because of COVID recovery. So that's something we need to be mindful of. Financially, we haven't required any additional costs from the CCG in terms of our budget, but we have brought in some significant external funding this year. A lot of that was towards the end of the year in March, so it was as a result of money coming into the ICS and then transferring into the ICP. So as a significant proportion of that it was carried over into this financial year to be spent. Those are probably the key points to highlight, but I'd really be happy to take any questions or suggestions for improvement.
Okay, thanks, Suzanne. Are there any comments, questions from anybody at all? Deb?
Yeah, thank you very much, Suzanne. I think you and your team should be highly commended for the 99% recommend. I think that is really, really good. And you say it's been a challenging year, and it's good to see that, you know, an organisation like Click is flexible. I think my question is, one of the things that needs to happen with the new white paper is, I think it's known as distributive leadership, which I think is quite a new concept to a lot of us. And I wondered if Click had plans to enable the new leaders, because you've got the fantastic collaborative element that we can all learn together. And, you know, the journey that we start on April the 1st, April Fool's Day next year, you know, it would be fantastic if we were already partly prepared by leaders having come together under the sort of distributive leadership, compassionate leadership model. But thank you for all you do.
Oh, thank you. Interestingly enough, the meeting I'm going to at 1:30 is a system development and leadership group, and we're going to be looking at leadership in focus. So we've had a first meeting. That's part of the delivery of the workforce priority for the ICP, but it's also linking to the regional delivery and ICS delivery for the workforce element of the people plan. So that group has met once and really was wholly behind that distributed collective leadership model. So we're building on that. We're really fortunate that we've got a good start in terms of what's already happening in organisations and how we're connecting together in North Cumbria. But we are really linked to what's happening in the ICS, because a lot of the ICS development will come from the North East Leadership Academy. And the senior responsible officer for this working group priority is Clive Spencer, who runs the Leadership Academy. So there are already a lot of offers coming out through the ICS, which we need to be able to access locally. But it's about looking at what we're going to do locally and what we can access through the ICS to get it targeted at the right places, but also get the best use of, you know, the collective offers that are available to us. And that's what the group will be looking at this afternoon.
Lovely,
Okay.
thank you, Suzanne.
Thanks, Suzanne. I was going to go Carol, then Mandy, please, and then I was going to wrap it all up if there was nothing else from anybody. Go on, Carol.
Thank you, Suzanne.
Thank you.
I just want to reiterate Deb's points. Really fantastic year, I think. The flexibility and the innovation that your team has shown is wonderful. And thanks for the report. I just had a couple of, one was a kind of a little technical thing, which I'll come to in a minute. But secondly, it was about the priorities. I think you highlight them on, is it page 8 of the report?
Yeah.
I just two parts to this. Firstly, how were those priorities kind of decided upon? What sort of process did you go through to you know, agree on those sort of 6 areas? And secondly, clearly you had a significant role in upgrading folks' frontline clinical skills during the pandemic, and I imagine that, you know, there'll be further need for that. And I was just wondering where in those 6 priorities the kind of ongoing work around updating and improving clinical skills was coming in. Is that under personal care? I just wanted to check that.
Okay.
So I've got one more,
Okay.
and the final bit was on your arrows at the beginning. I think one might, maybe I've misunderstood, but I think one might be should be green instead of red.
Oh, right, I'll check those.
The third one down, the attendances at the clinical skills events. I think that should be green, but maybe I've misunderstood.
Right.
That it's,
I've got a black and white version, Carol, so I'll have a look after the meeting and check.
Okay, and maybe one of the others as well. So just have a quick look at the greens and the reds.
I'll double check.
They're nearly all reds, and I think some of them might need to be greens. So just have a look.
Thank you for pointing that out. That's my big picture, not detail personality. So the priorities, we did a big exercise. So we brought 17 of our representatives from partner organisations across health and care. We included the third sector, CNTW, county council, etc. And we looked at what we were already doing and what we were learning in terms of what's the need from our sort of collective leadership community. And then we looked at what the health and care strategy was requiring us to do. And we'd done a bit of a skills gap analysis with the Cumbria LEP. So we took that information from the sort of top down from the strategy, bottom up from what we know the gaps are. And then we looked at what we could do together. So where are the themes that run across together that we're all doing? And in that way, we can add value to what's happening in organisations, but reduce duplication and get the best use of our resources. So that's how we came to those. So they're kind of themes that run across. So we've still got the 3 strategies, which is around our education and clinical skills programme, which will continue, our improvement, and also our leadership programme. So those still remain. These are the sort of the themes that run across, if that makes sense.
Okay.
Thank you.
Thanks for that, Suzanne. Mandy, then I noticed, Mark, you've got your hand up, so we'll finish with you. Go on, Mandy.
So, I mean, quickly, I think the value added by Click.
Sorry, I can't hardly hear you, Mandy.
Put my thing
There
back.
we go.
So I think the value added by Click is very obvious for us as a clinical leads team. For example, on a CCG level, Suzanne very helpfully supported us to do our OGIM because I haven't done one for a while. So the clinical leads team really found that really helpful, Suzanne, and that'll definitely help us going forward. I thought the ICC workshop, again, the facilitation that you provided on that on Tuesday was phenomenal. And I think as a system, we need that from Click going forward. But the last thing was as well, when I was asked to do a paper for the ICS regarding clinical leadership, one of the questions they asked was whether we thought we needed an ICS clinical leadership program, and we actually said we think we've got a really good one that's run here in North Cumbria over the last couple of years, and we think we would really like to see Click contribute to that. I know a lot of my clinical leads when we looked at that paper, they all said the ones that have been involved how useful they found that program that you delivered over the last couple of years. So thank you for that, Suzanne.
Thank you.
Thanks, Mandy. And Mark?
John, just very quickly to say thanks, Suzanne, for this excellent paper, and also, the value of Click just stands out. And I think just coming back to, Deb's issue, etc., it is really important how we think about using Click and the knowledge, the skills and experience of Click going forward into this new world, especially with everything about distributed leadership. I can't even say it. And the things that we'll have to tackle in terms of being a system. So I think really important for our organization, really important going into the new world, but also really important for us as an ICP system as well. Thanks.
Thank you. And just on that, I think we're really fortunate because the priorities for the SRO, so for the system development and leadership, there's lots of things. There's things on like values-based commissioning, there's clinical leadership is on there, but Click is one of the priorities. So we're really well connected. So I'm delighted on that.
Okay.
Thank you.
Right. Thanks so much, Suzanne, and hopefully you'll be bang on time for your meeting as well. So
thank you very much.
Appreciate the work you're doing.
Check my arrows. Thank you
Check
very much, everyone.
Right.
Bye.
Thanks a lot. Thanks,
Bye.
Maria. Okay, so we just asked to note that there's a couple of technical things there, Carol. Thank you for pointing out, so that maybe Suzanne can look at. So I'm going to move us on swiftly to the COVID update. Just Peter, just a verbal from the current position, and then maybe yourself had anything to do with vaccination. But I'll let you start, Peter.
Yeah, good morning.
Right.
Sorry,
Afternoon.
afternoon even. Afternoon even. Yeah. And I was momentarily distracted because isn't it lovely to see Colin back in the office with us? So
Yes.
welcome back, Colin. A brief overview. So around about the 22nd, 23rd of May, something like that. Across Cumbria, there were less than 20 new cases per 100,000 population per week. So that's the standard rate that we've been tracking since the beginning of the pandemic, really. It was under 20. For the week ending the 2nd of July, the Cumbria rate was 240. So there's been a very significant rise in case rates throughout June. And I think it is safe, at least technically, to talk about exponential growth. That is what has been seen. For the week ending the 9th of July, so these are the latest figures in the public domain, and it would clearly be inappropriate for me to introduce in this public meeting things not in the public domain, but for the most recent week where that's available, week ending 9th of July, the Cumbria rate is 403 per 100,000 per week, which was nearly a 70% rise from the week before. And that's a function of two things, or definitely one, possibly a second. So the possible has been the work done around surge testing. So, for example, across Cumbria, younger people have been asked to voluntarily present for PCR testing without symptoms as a way of identifying particularly those cases where people are not experiencing symptoms. So possibly there is a surge testing effect. The definite effect, though, is very simply more people are contracting the virus. Now, high case rates, thankfully, have not resulted in high numbers of severe disease. So the vaccine is clearly highly effective at reducing severe disease, but not preventing all severe disease. Sadly, some people who do have both doses of vaccine will still contract the virus and will still experience being very ill. So it completely weakens the link between cases and severe disease. It does not remove the link. As of today, we're now into double figures, but low double figures of people combined across West Cumberland Hospital and Cumberland Infirmary Carlisle who do have the virus and have been admitted with COVID. So there's very good tracking, as you would expect, of that going on. Thinking a little bit speculatively, there's an open question really about how high case rates may become. So it does seem likely on all current trends that the community case rate will exceed the peak rate that we experienced on the 8th of January this year, to be exact, was the day when it started to diminish. So it's likely that will be exceeded on the really simple basis that this is a highly transmittable virus and the social controls that prevent transmission are reducing. So I hope I'm not saying anything particularly contentious or in fact insightful. What is very difficult to understand is how high the case rate may become. So that's one unknown really. In terms of severe disease, the more people who contract the virus, the more that there will be people who are ill, despite the benefits of the vaccine, which are very real and for which we should all be enormously grateful. And the potential impact on the number of people who experience all things across the various syndromes grouped together as long COVID, there may well be a significant long COVID impact. It does appear likely that the vaccine gives all kinds of protections against syndromes and symptoms associated with long COVID, but that evidence is clearly still emerging. So overall, that's quite a big, massive positive on the vaccine programme, giving great protection to those people who've had the second dose, etc. But it is not a full and complete protection. Just to say that. The two impacts that are really being seen right now, today, in health and care services are firstly staff absenteeism. So people who have contracted the virus or are self-isolating or are providing care to people, typically children, who are self-isolating. So there are very high numbers of the health and social care workforce who are not in work as a direct consequence of the virus. And for as long as the current rules and regulations around self-isolating continue, and for as long as we have very high community transmission rates, there will be a workforce impact. So that's the first thing. The second thing is probably an indirect consequence, or not as immediately direct, perhaps more accurately, which is that we are now experiencing very, very high levels of demand for healthcare across primary care, secondary care, mental health, physical health, children, adults, everywhere, which is perhaps partly a consequence of people not accessing services during the pandemic period and now feeling confident that they can safely present. Changes in health seeking behaviour, perhaps the public think that the NHS is in a good place now because we don't have high numbers of COVID hospital admissions and so on. Perhaps as a consequence of delayed or deferred treatments or delayed presentations, people are now more ill than they would have been. But there's definitely been here in Cumbria very high levels of presentations to accident and emergency departments and admissions to hospital. And I know that our primary care colleagues are describing something very similar in general practice, as indeed our mental health and learning disability trusts. That last part is not unique to North Cumbria. Ed's with us this afternoon. Ed has the joy of being CCG director on call this week for North East North Cumbria. And this is a feature all across the region and probably all across the nation. So I know I've rambled a bit, John, but in summary, case rates getting really very high. A reasonable possibility that they will exceed the maximum case rates we had even in January. Severe disease still, thankfully, is low, but there will be people who will be severely ill. Big impact on the workforce and a real change in public health seeking behaviour and people presenting with genuine illness and actually quite often very high acuity. I'll stop there. Ed, I'm sure, will be able to give an update on all the positive things around the vaccine.
Okay, thanks, Peter. And before I open up to questions or comments, I'll deal with yourself straight away, Ed, if you're okay, just to give us the update on the vaccination.
Yeah, that's absolutely fine. Thank you. So the figures as of Tuesday were 89% of people in North Cumbria have had their first jabs and 72.8% have had their second jabs. So that's a total of 434,000 jabs that have happened since December. It's fair to say that there are more vacant slots opening up. People are starting to not turn up for appointments. We've still got a little way to go, so we're probably 4/5 of the way through the whole programme. So the drive over the next few weeks is going to be targeting those pockets of people that haven't come forward for their jabs yet. So we'll start to be doing some analysis around areas of deprivation, certain groups that experience inequalities. And to deal with that, we're going to be targeting comms for each of the PCNs. So we're going to be working with each individual PCN, say, from your population, where do you think we need to work? And we've also now got our hands on a roving model, i.e. a St John's ambulance that we can take round and really start to drive some of those really smaller pockets of people that haven't been vaccinated yet. So on the Health Protection Board tactical group this morning, we were talking about there's some potential huge hotels where we know a lot of people haven't been vaccinated in them, There are some big factories and some big employers. So we're working with colleagues across Cumbria to identify some of those pockets so that we can tootle around with our roving model and see who wants to come forwards. The only other thing to say is the guidance came out yesterday around phase 3 of the programme. So this is the boosters. So NHS England released guidance yesterday around, and JCVI guidance about how we're going to be tackling the phase 3. So once again, there's going to be 2 stages of that. The first starting in September, early September. So high priority areas, the more elderly, care homes, health and social care staff, those that are clinically extremely vulnerable will be the first ones around the booster programme. There's going to be a huge amount of operational issues because it's coming out at the same time as the flu vaccination programme. So the hope is that we can give them together, but it's not that simple in that practices order their individual supply of flu vaccines months and months and months ago. And so we then need to try and pair up those vaccines with the COVID booster vaccines in some way. So there's going to be a massive operational issue around that. So yeah, boosters should be out from early September through to just before Christmas.
Thanks, Ed. Okay, any comments or questions in terms of that? John? Sorry, John, you're going to have to unmute yourself.
Apologies. I've got 2 comments or questions. I'm not sure if they're questions. One involves something that Peter said, or I'd like his view on, and one's for Ed. So if the disease is going through the population exponentially, there is a theory that once it's been through the population, everybody's been exposed to it. But given the fact that the schools are breaking up, and my experience with my grandchildren is all their bubbles keep popping and they keep getting sent home. When we go back in September, there's a lot of children going to go back, and it's going to reinvigorate the disease well into the autumn and put extra pressure on the service and indeed the population who suffer it. So I just wonder how that had come into any modelling, Peter. That was my first query.
Okay. So John, it's definitely the case that the issue about school bubbles have had a big impact on staff who work in health and care services, well, across all industries, but staff who work in health and care services needing to be absent from work to provide care for children who are required not to be at school. So that's definitely an impact. I don't think it's been nationally determined yet what, if any, approach there'll be to isolation for children and school bubbles in September. But we're on a clear trajectory, aren't we, of removing those kinds of practices. So there could easily be an impact in September. On your earlier point about people being exposed and so on, of course, the evidence is still not particularly strong about duration of antibodies and so on. So we should all be extraordinarily careful making any assumptions that once we've all had it, it'll kind of be okay. I think that would be I know that's not what you're saying, John, but that would be a deeply unsafe assumption and would be contrary to the reason why we're actually offering booster vaccines that Ed just described to ensure longevity of antibodies. The school thing will also, though, very much potentially have an impact on children's respiratory illnesses, which weren't a feature last winter. Viral croup, that kind of thing. You know, GPs pretty much didn't see kids with those presentations. Well, they're starting to emerge now, and they may well emerge very strongly in the autumn period, as may seasonal flu. So there's all those other dynamics about the restrictions that we all lived through gave the population protection against other viruses, which may well not be the case this time. So there's to my knowledge, John, no detailed modelling about what impact children going back to school would have in September, but it will almost certainly have an immediate positive impact in reducing the number of staff who are off work, being required to look after children who are within those bubbles, etc.
Thanks, Peter. My second point was to Ed. Last time, Ed, we talked about the strain on staff giving vaccinations and the battle fatigue. And I just wonder how staff, they must be very tired. We just wondered how they were sort of looking forward to another season of vaccinations.
Thanks, John. So yeah, so we're scoping that out at the moment in terms of the guidance that came out yesterday is asking each of the providers to sign back up to a new enhanced service, a new contract, if you like. So we're scoping out at the moment who wants to be in that phase 3. And let's not forget that we've got 7 community pharmacy sites as well as the Penrith Vaccination Centre as well. But you're right, people are getting tired. As Peter described, demand across the system is as high as it's probably ever been at the moment. And in addition to that, there are staffing issues around people being pinged. And then there's the vaccination programme that they are A, continuing with, and B, looking down the barrel of phase 3. So it is a massive concern on top of a primary care structure at the moment that is seriously under pressure. So massive concern. We're working through it step by step. But the hope is that everybody realises the importance of delivering this programme, and I'm sure everybody will pull out every stop they can to make it happen. But yeah, people are tired.
Okay, thank you, Ed. I'm going to go Carol, Louise, then Deb, and then we'll curtail it there. So go ahead, Carol.
Thanks, both Ed and Peter for your updates. Peter, this might be a question that should be taken under the performance report, so apologies if it's meant to be there. Given the massive demand on all of our healthcare services, I'm wondering whether or not our recovery planning and our trajectories for cancer services and the work we're trying to do with the work that we're doing on diagnostics to improve the waiting times, how that is being impacted on, or whether we actually anticipated this level of demand and built it into the plans that we've done. So it's just a bit of information or a bit of a guide from you on whether or not those plans still remain robust or whether they need to be revisited. I mean, I know it's going to take a long time for the recovery. Is it going to take even longer? So that's the first point. I'll come back to the other ones.
So in brief, largely not any observable bad impact on that recovery yet. Particularly colleagues working in hospital trusts are doing a fantastic job maintaining elective work despite the pressure. So no noticeable bad impact yet. Of course, that's not to say that we won't have to keep revisiting those plans depending on how winter develops, etc.
Thanks, Peter. And then the second point was, I'm imagining that because of the vaccine, most people are a little bit unwell, but not that unwell that they need to be hospitalised. As you said, the link's greatly weakened. So in terms of all the additional demand on care, are we seeing an equal demand on primary care, so the majority of people concerned are coming to the general practitioners, and that is really worrying because I'm imagining that the primary care is getting the bulk of these slightly unwell people and concerned people.
Absolutely and definitely, Carol. Yeah. But the driver demand is not about COVID illness.
Okay.
I just want to be a bit clearer than obviously wasn't clear. It's not about COVID illness. It's about people with other presentations who have either not come forward or have had delayed or deferred or disrupted treatments, or have just become more unwell and not received the kind of routine healthcare that they would have accessed. That's much more present than the kind of COVID impact, though there is clearly one. It does appear to be more of that general illness. And of course, there are some emerging evidence about coincidental comorbidities or causal comorbidities associated with COVID, and that will doubtless develop over time. But I think it's more a feature of changing health-seeking behaviour.
Thanks, Peter.
Clinical colleagues might have a better view than that, but
I'll go with that, Peter, because I'm going to move on to Louise and then on to Deb. Go on, Louise.
Thanks. So it was really just a bit more in response to John's question, because obviously the anticipation is that the rates will increase well before schools return. We know that the worst case scenario modelling from SAGE gives us up to 100,000 by the end of August, based on obviously that release.
And again, Colin shared some I don't know, comparator in terms of sort of the very early part of January. At that time, when we had rates that were roughly equivalent, we had 280 people in hospital and 50 deaths in the previous week. Now, obviously, although we've had 2 deaths related, I think he was just trying to give us some sort of context, but we also know in January that we were another 10 days at least into the peak of those numbers. But yeah, so it's just to add, you know, the expectation is that the spread will happen before the schools return, and the vaccination programme obviously will catch up with those younger cohorts. Thank you, John.
Thanks for that, Louise. And I think Mandy reflects that in the comments she's made about that's the modelling suggests that the children's respiratory and viral illness will actually peak during the summer months rather than the winter, although NCIC are already starting to see some cases on children's wards. So she's put that in the chat. So thanks for that, Mandy, and thanks for that, Louise. Deb?
Yep, 2 comments really. One, given the exponential growth in Cumbria and the fact that the North East has 8 of the 10 hotspots in England, has the ICS made any sort of formal comment to the government about their way of talking about freedoms when one of the risks of these huge increase in the amount of COVID is that actually a vaccine resistant version will arrive? So that's the first question. Might be aimed at Mark rather than you, Peter. And the second, Ed, is I think what you've done in the vaccination is a really good model again for the new NHS white paper, where we're focusing on inequality, how we make it easier for people to reach our services, and also that collaborative approach. You mentioned you're using an ambulance from St John Ambulance and things, and I think it's a really good model for the future. So thank you for that.
Mark, are you wanting to step in? I think Peter did defer that to you. I noticed the signal, Peter. Yes.
Deb, I'm not aware of the ICS making those kinds of representations in quite the way that you said, but I know that there is a very clear focus on our ICS and the North East, regionally and nationally, because we do appear to be an outlier. So I think it will be very much a two-way conversation, shall I say. I know there is something that's gone from our ICS to the centre about our particular position. I think there are 1 or 2 places in the country, but I think that we are a particular outlier, and I'm sure those things will be part of that conversation.
Thanks, you.
Mike. Okay, I think I've covered everybody there, so I'm going to move us on. But thank you both, Peter and Ed, for those updates. Always very useful just to hear that, and thanks for the questions and comments. So I'm going to shift on to item 5, decisions taken under emergency rules. Am I going to catch some time up here, Charles, on this? Is it a no, as it has been for the last few meetings, or have we got something?
I think we will very much catch some time up on this, and note sort of this issue to some extent has been covered a bit later in the agenda too, in terms of the process. So nothing to report. There's
nothing to report in terms of emergency rules. Thank you. And then I'm going to introduce Mark for the Chair and Accountable Officer report, but I'm going to base it on the fact that everybody's read it back. So I don't know how you want to manage that, because I know I'll let you pick out anything you want to pick out, but then I'll pass it open for questions.
So on the basis that everybody's read it, there is a piece in there about the ICS design framework, and we'll be coming on to that in part 2 in the meeting. So I won't not talk about that any further. I think it's worthy of note the development of West Cumberland Hospital. We have supported the business case, and that is now on its way to NHS England. I think it's also useful just to note also the proposed change to the overnight access to Penrith Urgent Treatment Centre. Again, I won't go into detail, but just to note that engagement with our public and populations started on the 12th of July, and that's a really important part of doing that. Just to thank, I think, formally Catherine for everything that she has done in the council, who's the outgoing chief executive, and we will welcome Jill Stewart when she starts very soon. And also, I think we've already raised this, but I think it's just worth formally noting how sad we are of Helen Horn's death, and we would like to thank her for everything that she has done in Healthwatch and also in our system for many years. Thanks, John.
Okay, thanks, Mark. Any questions or comments there? I know some of the items around the ICS development we'll pick up in the development session later on, so I don't want to dwell into those. Mark, you've put your hand up, Mark. I didn't. All right, okay. I took it. That was just a little mistake. That's okay. Anything from anybody before we move on? Okay, thank you for that. We have one item for approval, which is item number 7, which is corporate governance arrangements. Charles, I'm going to hand over to you and obviously take it as read that everybody has read it. Yeah.
Thanks, John. Hopefully this will be relatively straightforward, and I guess there's 4 points here. So a lot of which actually relate back to the discussion on COVID earlier. So the first point is just to suggest it was actually back in April 2020 that we introduced some interim governance arrangements just to reflect that we weren't necessarily or wouldn't continue on a business as usual purpose that we've had in place since then. What we're proposing is just to extend those to November. Now, the reason for that isn't necessarily so we can do lots of things out of normal business, because as per the previous item, actually we've had to take very few emergency decisions, if indeed any, and actually we have been able to work pretty much normally, which we will endeavour to do. But this is just to say, in the event that things continue and we're not able to do that, we will just carry on. So it's more a contingency measure that we will work in this way if we have to, but actually we'll try and work normally. I'll just run through the 3 sorts of decision items. The second one was just to say, as in a business as usual situation, we would normally review the work of the governing body and its subcommittee in terms of terms of reference, etc., what we're doing. And I think, given that the white paper is, well, yesterday was being read in Parliament, second reading, the expectation is that in response to that, there may be some plans to possibly to start doing some of the work in advance of next April beforehand, and perhaps to support that, some interim arrangements of the way CCGs work. So on a purely expedient basis, we're saying, well, we don't really want to be reviewing the work of all our committees now when A, to some extent, we haven't been working in a normal environment because of COVID, and B, it's like there may be some changes afoot anyway. So in terms of not wanting or to want to reduce waste, it just feels like it's not the right time to do this, but we shouldn't sort of take it as a cop-out not to do it. It's just we need to formally acknowledge that. And then the third one is in the same vein, which is to say we deferred seeking conflict of interest statements from our GP practices. A lot of the things we would normally work discretionarily on, we haven't been doing anyway because of COVID and the COVID financial regime in terms of contracts and things like that. A lot of resources to primary care are all predetermined by national decisions, not by ourselves. And given the feedback that we're getting, going back to the COVID item earlier, how busy primary care is, we just felt this was an item. It again needs to be done, but perhaps doesn't need to be done now. So those are the items for approval, and on top of that, there's just some information about the paper, about how people can access our register of interest and all the associated work that goes with that, because it's still really important. Despite what I've just said, we still act in a responsible manner for the public purse, take account of value for money in our decisions, and make sure we properly record interests. It's just we might be going about our business a slightly different way, but we still need to do those things. And that's it from me on this item unless there's any questions.
Thanks very much, Charles. Are there any questions or comments? So everybody see the logic in that? I've seen a few shaky heads, as in everyone's comfortable. The only thing I was going to mention, Charles, it is mentioned in your kind of main body of the report about the Council of Members and the deferment of the register. I was just going to add is that there may well be a Council of Members meeting, but it might not be anything that involves voting, where then I don't think you say filling forms in. So I just wanted to amend that slightly to say that for the third one, the approved deferring declaration of interest requirements from GP practice until March 2022, unless a council of members meeting takes place involving voting issues. If it doesn't, then we don't need to do it. So we may well just be passing information at some stage. Is how I want to do it. Does that make sense? Yeah, happy with that?
Makes a lot of sense. Yeah, very much so, John.
Okay.
That's very helpful.
Okay, so I've got there just in terms of those three items then requiring approval. We'll take them all together. Is there a proposer and then a seconder for those?
Happy to propose, John.
Thanks, John. Seconder, Deb. I think I saw an arm just waving there, Deb. So I'll do use a seconder. Is there any objection to those in terms of the approvals? Not at all. Okay, thank you. And then we'll obviously note the bit about the register specifically for the minutes. So thank you very much for that, Charles.
Could I just say thanks to Brenda because she's done all the hard work on that.
You can, and I think I saw something where Brenda disappeared somewhere, but I take it you're back again now, Brenda, are you?
I did disappear.
Yeah, okay, that's all right. Right, that's all right, no problem. Okay, at least you heard that then. So thank you, Charles, as well, and thank you, Brenda. Item 8 for discussion. This was just a verbal update, Peter, which was around the send update report, potentially where we were. So I'm going to hand over to you for a quick verbal on that, please.
Yeah, I'll be very brief because I think John, we'd included this partly in anticipation of the re-inspection from Ofsted and the Care Quality Commission for Special Educational Needs and Disabilities across all of Cumbria. Because of where we are now in the time frame, Ofsted and CQC do not undertake send reviews during the school holidays. At least it would be truly exceptional were they to do so. So we do still anticipate an inspection at some point, but it won't be until the autumn. We are taking a bit more opportunity though to look at making sure we've done the very best job possible, not for the purpose of the inspection, but for the purpose of these children, young people and their families. So that we've carried out the kind of full self-assessment and so on that you'd expect in advance of an inspection. And there are some areas where we've got lots of work to do. In send inspections, if the inspectors are not satisfied in re-inspection, that you've addressed all of the areas that you needed to cover in the initial written statement of action, they can insist upon an accelerated process to address those deficits. So based on our own self-assessment, we're going to do that work over summer anyway. And that'll kind of be overseen by the responsible officers here being myself and Hilary Fordham from Morecambe Bay CCG and John Redmond, the Deputy Chief Executive at Cumbria County Council. So lots of work still ongoing, but it would be extremely exceptional if the inspection actually took place any time in the next 7 or 8 weeks.
Thank you, Peter. And in that vein, I suppose we should maybe look to having it on our meeting in September, 16th of September, in terms of an update as to where we are for the send.
I'd propose, John, that I'm slightly, in a way, I wish this inspection would happen.
Yeah.
Because we can't keep everybody in an inspection readiness state. And keep having it for updates all of the time. So if that's what you'd like to do, then no problem. But I would suggest that we actually bring back an update at the end of the year, or if the inspection actually occurs, if that would be acceptable. Yeah,
okay. And I'm just conscious, just trying to keep it on in forefront of everybody. But as we do know, it is discussed on a regular basis at the Health and Wellbeing Board, which looks at it from a partnership perspective. Okay, Charles, did you want to add something to what
I was just going to say that's a very sensible proposal, and I would guess perhaps some more of the detail, maybe at quality and outcomes or something like that, we could use as a way to keep the governing body appraised if there are any specific issues in the interim as well.
Okay, so what we'll do then is we'll look at this on the basis of if an inspection is done, then obviously we'll get the, you know, we'll put that in after the meeting, and we'll also use quality and outcomes as potential for people to keep updated, particularly around the sort of lay representation, which you chair, Carol. You're quite happy for that to happen? Yeah. Okay, as and when required. And if not, then if you've not had anything, we'll look towards the probably November meeting, maybe as a before the end of the year, if we don't get any kind of inspection before then. Does that sound, is that in line, Peter, with what you were proposing? Is that okay? Yeah.
Very comfortable, thank you.
Yeah.
Thanks.
Yeah. All right. Okay. Thanks for that. And I see that obviously Mandy supported that as well, so that's useful. So thanks for that, Mandy. Okay. We'll note that we've done item 9 and on to item 10. It's 10, 11 and 12. We are kind of running short on time, and I do know that there has been a quality and outcomes meeting prior to this meeting, but the performance and the finance are going to be considered next week at the finance and performance meeting. So it's a little bit out of kilter to what we would normally do, but let's go with what we've got on the basis that people have read these. Louise, I'm going to hand over to you just for anything you want to specifically pick out from the quality report, and then maybe ask you to join in, Carol, if there's anything you wanted to mention. But over to you, Louise.
That's great. Thank you very much, John. And as you've reflected, we did have a very comprehensive quality report to the Quality and Outcomes Committee recently. Obviously, referencing the current challenges we continue to face working with the waiting lists and backlogs, and obviously our role in terms of the oversight of those harms, and our continued close working relationships with commissioners and regulators. Obviously, colleagues will note that there is a maternity never event recorded in the dashboard. But again, just to note that the CQC have undertaken a recent monitoring. It's a call, obviously, now rather than a visit. And that was extremely comprehensive. And we did get some really positive feedback to the Quality and Outcomes Committee regarding that. So again, some positive developments from a maternity point of view. Other finally, just brief things to note. Obviously, as the end of life collaborative has now been re-established, end of life is clearly a key area that we wish to make improvements around. And we've also constituted the North Cumbria ICP healthcare acquired infections group as well. So again, all real positive developments, notwithstanding the conversations from not just COVID, but other infections. So the NCIC Quality Board is next week. And the very final comment is, which isn't in the report, but just to let colleagues know that Ofsted have announced that they are going to do a focused inspection of children's services. So that's for the County Council, Children's Services, obviously as statutory partners. It's just to make colleagues aware of that, and any outcomes obviously will again report through the safeguarding route through to this board as required. But nothing else from me unless anybody's got any questions. Thank you, John.
Okay, thanks, Louise. And just what the County Council in terms of their children's service, are they still at requires improvement? Louise, is that the level that they are at? Yeah. Okay.
Yeah. So
Right,
there won't be a change in judgment when they do a specific injection. I was going to say inspection like this. They won't change the judgment.
Okay.
Thanks.
Mandy, you got your hand up. Then I was going to ask if Carol wanted to mention anything. Go on, Mandy.
Yeah, so I think it's on the quality and on the performance report. Dementia diagnosis in primary care is another area that's been highlighted. So it's just to update the governing body as well that we've reinstated a North Cumbria dementia strategy group, which is a multi-agency group, which met for the second time on Monday. So we've got really good representation from across third sector, adult social care and health, all working together to try and see what we can do jointly to try and increase those diagnosis rates, which, just for the record, did drop off because of the COVID pandemic nationally, but we are a particular outlier across our North East and North Cumbria patch as well. Here in North Cumbria. So, but lots of really positive conversations about how, as a system, we're going to try and work together on improving those rates and making sure that we get patients diagnosed on the right pathway and on the right treatment. So really positive steps, and more than happy at a future governing body or quality group to bring a report once we start making some inroads into those actions.
Okay, thanks, Mandy. And I'll pick that up at the end for questions from the members of the public, because I know that Sue Gallagher has sent us someone. We'll try and weave those two things together with, you know, that you just mentioned. Yeah.
John, I'm going to meet with Sue next week, so we don't need to pick it up here at the
No,
meeting.
no. I just want to mention the fact that that's what I was going to do. No, I'm not going to go through the answers. I'm just going to mention that you're meeting so I can put it in the right place, particularly for Lynn, who's doing the notes. Carol, anything you wanted to mention at all, Carol, from your role as chair? No,
no, nothing further to add. Thanks, John.
Okay. All right. Is there anything from any other colleagues here? Okay, well, we'll note the report. Thanks very much for that as well, Louise. And the next one in terms of the performance, item 11, Charles, there's some kind of crossovers obviously with the quality report, but I'll let you tell us anything you want to say for us from the performance side of things.
I think so. Mandy's picked up on the dementia angle. I'll just be quite brief again, if it's okay. So this is the one that's the wrong way around, because this is the most up-to-date performance report that we're going to be discussing next week at Finance and Performance. Although, to be fair, a lot of the information, there's a sort of ongoing theme. So I think it's just worth reminding everyone, as part of the plan this year, there is considerable investment going into mental health services. So we'd expect to see an improvement as the year goes on in those areas. Obviously, we've picked upon the backlog and the risks on elective and cancer care in the acute sector, although we would note that I think North Cumbria are ahead of trajectory in terms of their recovery, which is an excellent place to be. We know that's also reflected in their finances through the Active Recovery Fund, but clearly what we don't know quite yet is what impact the current escalation, which, as Peter said, isn't having an impact on activity, but will that remain the case? I think the other point just to note is in terms of ambulance services, actually, is to say, I think one of the advantages we have, which is an unusual one of being a geographical outlier, is actually the performance in North Cumbria of ambulance services for quarter 1 is managing to hold up, and that isn't the case at the moment across the whole of NWAS. And particularly if you look on the second page of I'll call it the DOTS report. I know that's not a very good way of describing it. If you see the North Cumbria figures compared to NWAS, particularly for the category 3s and 4s, the less urgent cases, even where the standard hasn't been met in North Cumbria, it's been marginally away from the average, as opposed to some very significant differences elsewhere in the patch. And it's just worth noting that the team that lead on ambulance commissioning have had a deep dive last week with NWAS to try and see what action they were able to take. Although, again, as noted in the COVID report, one of the big pressures they've had is paramedic staff having to self-isolate, which is a common theme across the piece. So I was just going to leave it at that, and obviously we can pick up a more in-depth conversation next week at Finance and Performance.
Thank you, Charles. Are there any specific questions from colleagues today? Or points? Okay, no, that's fine. So we'll note that. Thanks very much for the report and efforts there. We're going to go on again, Charles, to yourself. Finance report, including our annual report and annual account, which I think is incorporated in your overview report.
Yeah, so in the overview report, and is referred to in the Chair and Accountable Officer statement, the annual accounts for last year are available on our website, and we'll have an annual general meeting when we discuss them in more depth as we normally do. So that was just to more to alert people. So if members of the public are looking, so I can hear some bizarre background noise at the minute, can see that. In terms of the financial position, what the report you've got is actually the main report, just because of the timing of the committee. we of the governing body, we have completed, after the papers went out, the June report, and actually we have a lot more information, although actually we're pretty much still on balance. I think 0.02% variance for June, so things are pretty much ongoing there. Clearly, at the time this report was done, we actually didn't have a lot of data on the variable costs, and as I will keep saying to anyone who wants to listen, at the moment the current COVID financial regime means a very large proportion, above 80% of the CCG's financial costs are absolutely fixed, and of that remaining 20%, a lot of them aren't going to change by much, because it's things like continuing healthcare, where we have packages of care in place for people, or GP prescribing, which may change by a few percentage points at the margin, but isn't going to change massively. And again, just to reinforce, we're currently working in the COVID financial regime. There was a national briefing last week in terms of what the financial position may look like going forward, although in summary terms it's likely to be more challenging than the current one, but quite by how much and how it's going to work, we yet to know. We understand that the H2 planning process is most likely to take place in the September to November period of the year, that sort of replicates where we are now. And clearly there are a lot of indirect factors as well as the direct ones that the NHS is facing, that I guess will be part of the discussions that the Department of Health has with the Treasury about the settlement for the second part of the year.
Okay, thanks, Charles. Any questions or comments from anybody on those? Okay, the only thing I was going to mention, just in terms of the annual general meeting, is we're hoping to do it in partnership again with NCIC, like we did last year. I know, Mark, that there's an initial date given for that in October, which I know you're unavailable for. I've asked Brenda to go back and say we wanted you to be there. So see I don't know why they've chosen that specific week, but we'll see if they can move it so that you can be there. So we'll just wait and see on that one. So thank you. There's no comments. I was going to move us on. Thank you. Okay. Just item 13 then, just the minutes of all the meetings from all the committees. I'll go in order and just ask the chair of those groups if there's anything they want to add from those. But basically, the exec committee, Mark, from the 14th of April and the 12th of May, is there anything you wanted to add from those, or just take it as read? Everyone happy? Yeah, okay, that's fine. Yeah. Finance and performance for myself, 21st of April and the 19th of May. There's nothing I wanted to add that we've not already talked through or had conversations about. Is everybody okay with those? Yep. Yep. Outcomes and quality, 11th of May. Carol, anything you wanted to mention or happy? Okay. And then finally, the primary care committee, 21st of April. Everyone comfortable? I am. Yep. Okay, there's no minutes from the wider system in terms of item 14. Just the questions which I did refer to. I was just going to, what I was going to say, Lynn, I just wanted to ask you, have you got a copy of those questions, Lynn? Just to put them down in the minutes. From John,
it's Brenda.
It's Brenda, right? You got.
Lynn's not going to be doing the notes. I'm going to get back from. Okay. So I've got the question. I'll sort that.
All right. Okay, that's all right. I was going to say, in terms of the first one, which was around the issue of the Home First across North Cumbria, Susan was just asking around any information about that. She's obviously a discharge programme, Peter, that you're involved with, so we can put something back to Sue about that. And obviously the bit about the dementia, where there's some issues there, which I know you've touched on, and you're going to meet with Sue later on, I think, next week.
Just to add to that as well, we're actually going to invite Sue Gallagher to be a member of our dementia strategy group. So David Storm, that chairs that group, has already had a conversation with Sue about joining that group. So she'll be very closely involved with that improvement work going forward, hopefully. Okay,
so could I just ask for the first question, Peter, if there's anything there you just want to give a couple of lines on, back to Brenda on about the Home First and what it's about. It's fine. Yeah, and then the other one's dementia. Mandy, the same for you, and then we can attach them as a appendix for the public part of this meeting. after you've met with Sue. So that's really good. Okay, I haven't got any other urgent items of business, and the date of our next meeting is the 16th of September at 1 o'clock. It's now 14:13. We do have to book in to for the part 2 and the development session. We have to come out of what we've got here and go into another room. So it would just be members of the governing body. Tony, I don't know if you understood that, Tony, but that's what we do. We normally just have ourselves as a governing body and CCG members.
That's absolutely fine. I'll leave now.
Okay.
Okay, thank you very much.
Thank you so much for attending, Tony. I really appreciate your time.
You're welcome.
So I was going to suggest we will start at 14:20. So you've got 7 minutes to get yourself sorted. We'll come back on there at 14:20 in the new thing. So I'll see you soon. Okay, guys. Bye-bye.